Peg is one doctor who doesn't always like a formal introduction, but we call her Peg. She is Dr. Nopoulos, and she is from the University of Iowa. And we have just such a great relationship between Help for HD and the University of Iowa. And they really wanted to be here and wanted to be a part of our program in person. And just due to everything that has been going on with COVID, they have decided to stay back in Iowa. And we miss them. We miss them terribly. She's a professor of pediatrics and neurology. And we are so thankful to have you here today, Peg. And I will just send it over to you so that you can tell a little bit more about what you guys are all doing up there. And we appreciate you so much. Her talk is called JoHD Symptoms and Symptom Management.
Good morning, everybody. It is absolutely true that I had very much looked forward to having our whole team there today and this weekend. And so we are really disappointed that we can't be, but we are grateful for a mechanism for us to still connect virtually. We're grateful for that. So good morning. I'm going to talk about particular symptoms of juvenile Huntington's disease, but I wanted to be a little bit more broad, make sure that we have all the basics down for everybody. Most of this is something you may have heard this lecture before, but in my opinion, having a lecture done twice or even 3 times is good, because duplication is good for the brain memory. The other thing that's most important is hopefully we'll have some time where I get to answer any questions. Let's see. This is just an outline of what I'm going to talk about. So I'm going to talk a little bit about genetics, about what the CAG repeat means, about what the term anticipation means, and then we're going to focus on the clinical features, and then the diagnostic challenge, which is really hard for most families, and then a little bit about our study in Iowa. So what about DNA basics? Very, very basic level. So this is anatomy of DNA. Like I said, most of you probably already know this, but it's good to review. I always like to review it myself. So DNA is code for the genes, and it's really like an alphabet. This code makes up a protein, and the code is made up of genes, and there's 4 nucleotides, T, A, G, and C. That's all there are. It's 4 words in an alphabet. An example of a code for a gene would be T, A, C, G, C. So you can have an infinite number of combinations of just those 4 letters. And then importantly, of those 4 letters, 3 letters make up a word, and 3 letters make up what's called an amino acid. And then you string together these amino acids. And one of the most common words is CAG. And actually what that codes for is an amino acid called glutamine. And once again, if you put those together, if you put amino acids together, you build a protein. Is something that just makes the cells run, lots of different kind of proteins. So the Huntington gene is called Huntington. We refer to it as HTT, so you'll hear that a lot. HTT is just shorthand for the Huntington gene. And it's normal in many genes, and it's normal in the Huntington gene to have repeats, so that there's a little bit of a word stutter where you have CAG, CAG, CAG. Every human has these repeats. It's normal to have them. And on average for humans, it's around 18. So this is just a representation of what a protein and those amino acids are. And when the repeat is longer than 40, that's when the gene is called mutant Huntington's, or MHTT. And when it's equal or longer to 40, that means that is when Huntington's disease will develop. So importantly, everyone has this gene, everyone has repeats. It's only when it's too long do you develop disease. And what's really important is that the age of the diagnosis is about 40 on average. But when the diagnosis is made before the age of 21, and that's an arbitrary cutoff, but when we call it onset before 21, that's when it's designated as juvenile Huntington's disease. So the onset of disease, like in adult onset, is determined by motor symptoms, right? So even though, we'll talk about this, even though there's cognitive and behavioral symptoms, when we say you now have the disease, it is determined by neurologic signs. Like I said, we call those motor signs. The other thing I wanted to clarify is that there's, especially, I think it was the Europeans, we work, it's a small community, we work with everybody worldwide, and we defined a specific group of patients with juvenile Huntington's disease as pediatric. And if you could just think about pediatrics as everybody below 18. So it's still juvenile onset, but currently that patient is below age 18, and we call that pediatric. I must say they use it in Europe. I personally don't use it a lot just because my brain isn't there yet, and it's a little confusing. But for an example, a child who was diagnosed at 13 and they're currently 17, so they're below age 18, they are pediatric Huntington's disease. If the child is diagnosed at 17 and they're currently 25, so they're over 18, that would be JoHD. And like I said, there's just some, in case you hear people talk about pediatric HD, that's the definition of that. So the CAG repeat and length of onset. So the longer the repeat, the earlier the onset. And you can see here by this graph that when you get to repeats that are 50 and above, you start to get earlier onset. So for instance, early onset is between 21 and 30. Those repeats are typically above 50. And then in general, repeats above 60 are typically juvenile onset, meaning that when you have a repeat 60 or above, you're likely to have motor onset of that disease before the age of 21. And please remember, all these are estimates, right? Because there's some people who may have manifest early, even though their repeats are not as long, but these are averages. So what does anticipation mean? Genetic anticipation means that when the gene is passed from a parent to a child, there is a chance that it'll get long. So an example is if a parent has a repeat of 43, they can pass that gene on, and that child will have now a CAG repeat of 65. So that's an expansion across the age when you transfer from parent to child. And it's much more likely to happen when the parent is male. That's why for juvenile Huntington's disease, almost always, not always, but almost always, the parent is male. And it's because that anticipation, or when the parent passes it on to the child, it's so much more likely to expand if it's male. Now, having said that, not every male with Huntington's passes on their genes and it expands. It's actually rare that it happens, but when it does, it's more likely to be male. So most cases, about 90% have a father with HD. And then, like I said, the vast majority of fathers with HD will not have a child with HD. So it's not like every single male will do it. It's rare that it happens. So what about the clinical features? So in many ways, it's the same disease as adult onset. So there are three categories: motor, cognitive, and behavioral. So like AOHD, so that's, I'm going to refer to adult onset Huntington's disease. So like AOHD, cognitive and behavioral symptoms can occur many years before the onset of motor. This absolutely happens with adult onset. It's absolutely true for the children. It's something that I'll talk about in a little bit when we talk about the diagnostic challenge. So once again, and I'd mentioned this, the definition of onset of disease is motor. So cognitive and behavioral changes long before the motor. Not always. Sometimes the motor can be the first thing. So the important difference between the two, between JoHD and AOHD, is the motor symptoms. So hyperkinesis, so kinesis just means movement. Hyper means excess. So AOHD is typically excess movement. So it's chorea, and chorea means dance-like. And so it's different, right? It's fluid motion, right? So this is a tremor. This is a motor abnormality, but chorea is more dance-like. And so it's a little bit more fluid. So especially at low levels, it doesn't look abnormal. It just looks a little bit like excess movement. JoHD is much more likely to manifest what we call hypokinesis, so lack of movement. So it is slowing, stiff, So it's the opposite of hyper, it's slowing and stiff. So the motor symptoms of JoHD are in walking, it is slow, shuffling, stooped. In many ways, if you know what the disease Parkinson's disease is, it looks more like Parkinson's disease. Bradykinesia, Brady means slow, kinesia means movement, so bradykinesia, slow movement. Rigidity, stiff muscles. Sometimes this may lead to pain. Dysarthria means talk, dys means abnormal, and so abnormal talking, so changes in speech and slurring. There can be tremor. Like I said, for hyperkinesis, chorea is usually fluid. With hypokinesis, you can get tremor. And then what we call a masked facies, meaning that there's not much facial movement. So these are symptoms that are much more common in JoHD. They can happen in AOHD. We'll talk about that, but it's usually at the very end of the disease, not at the beginning. So in terms of the cognitive symptoms, so cognitive skills, cognition just means thinking. So this is everything from general intelligence to very specific functions like memory, attention, and language. For children in childhood onset, and I'm sorry, I didn't define childhood onset before the age of 10, if you have Huntington's that early, then what you're going to have is you're going to have a failure of learning. But for onsets that are later than that, later in life, then what you have is you have, some learning early on, and then you have loss of skill, right? And so in general, there's always eventually a worsening of skills, but depending on when that child gets it, it'll be a lack of learning if it's very early on, or you learn something and then it gets worse over time and you lose those skills. So behavioral psychiatric symptoms are very globally broken up into two categories, what we call externalizing behavior and internalizing behavior. Externalizing behaviors are behaviors that other people can see. That's why they're called external. So it's hyperactivity, it's inattention, it's opposition, not wanting to follow rules, talking back, aggression. And internalizing behaviors is what people feel inside. So it's feeling sad or depressed or anxious or obsessional. And in general, for both AOHD and JoHD, the behavioral psychiatric symptoms are more common. It's not at all uncommon for children who later get the diagnosis of juvenile onset Huntington's disease to get the diagnosis of ADHD. And we'll talk about that later. And it could be that this is actually the earliest form of chorea, and that it's in a child, it looks like ADHD and they get the diagnosis of ADHD. Aggression may come on in many ways like it is in adults. And I talk about the aggression of Huntington sometimes almost like a seizure, because it can happen really quick without seemingly a trigger, and going from 0 to 60, and then in a rage, and then sometimes a quick offset, and then looking back on that and whoa, I didn't know what happened there. And so it can be very difficult to manage for everybody, not only the patient, but everyone around them. And like I said, it's a very similar kind of presentation for juvenile and adult onset. Seizures is something that is seen almost exclusively in juvenile onset. We don't see seizures in adult onset Huntington's disease, but for many, and especially for the earliest onset, it can happen. And the seizures can be of any kind. So in general, seizures can be what we call grand mal, which is where they lose control on the ground, shaking, unconscious, all the way through to what we call petit mal or absence seizures, which is just staring off into space, maybe doing a little bit of lip smacking, but just staring off. That's a whole spectrum. And there's different, so to speak, flavors of seizures. And there's nothing that's more common than the others. But once again, in general, seizures are more common with the earliest onset, with the childhood onset. When I started working with the JoHD community, what was really striking to me, because it's so rare, is that the families taking care of these children knew far more than any doctor I can guarantee you that. And so what I did is in 2017, I worked with the community to send out a survey because I knew that this community is so full of knowledge. I just needed to gather it together because I thought that there was symptoms that some parents were telling me about that I had never heard before or never read in the literature. And so we sent out a survey. We got immediately great response. And what we focused on was some symptoms, like I said, that wasn't in the literature and that most people weren't talking about. And that was sleep disturbance, tics. So instead of fluid movements like chorea, tics, which is quick movements that could either be, it can be like in the mouth, clicking tongue, or it can be moving a neck. Pain is not something that we see in adult onset HD. And a really rare symptom of itching when there's no rash. And then psychosis, which is hallucinations and delusions. So these were things that some of them we do see in AOHD, but not that common. But some of these were really specific to pediatric and juvenile Huntington's disease. So we got 33 responses, which was, and we got them like bang, 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 really quick. It was really great to see and just immediately being able to get this data. And so out of those 33 patients, the age at the time of their diagnosis on average was 12, but it was everything from 3 to 21. The time in which the parents were filling out the survey, their child with JoHD was around the age of 15, but ranged from 4 to 27. And the CAG repeat length you can see was very wide, 45 to 109. So what you can see here on this graph, the y-axis, the vertical axis, is the percentage of patients who had that symptom. So you can see here that 87% of caregivers of JoHD patients said, my child has problems with sleep. And to be honest, over 50% qualified that as being severe problems. And it was everything from initial, meaning not falling asleep, middle insomnia, meaning falling asleep and then you wake up and you can't get back to sleep, terminal insomnia, which means you fall asleep, but then you wake up early, and 10% had night terrors. So the whole sleep disturbance was very common and quite severe. Tics were also very common. Blinking, sniffing were the most common. And pain was common. Legs were the most common site of pain. 20% called this severe. And then itching, once again, not associated with any skin irritation or rash, occasionally described as pins and needles. 40% called this severe. This was the only symptom that was correlated with CAG repeat. What I mean by that is that the children with the youngest onset were the ones that were most likely to have this symptom, the itching symptom. And then the psychosis, the hallucinations and delusions. In general, in my opinion, mostly those are more common for the adolescent onset. That's what I've seen clinically, is that. So the diagnostic challenge, I don't need to tell any of you in the room how difficult this is because you've lived it. And the reason for the challenge is something that we're trying to make better for the community, one of the reasons why we study. But the average length of time for when families say this is when symptoms started and the time of diagnosis is 9 years, which is crazy, stupid, too long. It's too long. And it's not nefarious, meaning it's not because there's reasons for it, but it's certainly something that creates a lot of consternation in families. The most common presenting symptom is behavior. And as I mentioned before, it's really common to have an early diagnosis of ADHD. And for childhood onset, presenting symptom is more likely to be motor. So that is one thing, is that for very early onset, presenting symptoms like walking problems are often sometimes the first rather than the behavior. But the big question is, oh my goodness, these families go for years with doctors telling them things like, oh, Huntington's doesn't happen in children, or, oh, no, this is not juvenile Huntington's because there's no motor signs. So it's really very difficult for families to walk through. And for every experience, it's always individualistic for families. For some families, the diagnosis comes more quickly. For some, it's longer. For some families, it's difficult to have the diagnosis. As for some, they would prefer that that whole length is okay. I don't want to know this diagnosis. So it's really also very personal in terms of how people experience this diagnostic challenge and this road towards diagnosis. But here's the thing, why can't the diagnosis be made when a child has ADHD? Why can't we just say, oh, you're at risk for Huntington's, your child has ADHD, let's go ahead and get the genetic test. So that can be problematic, and let's just walk through why. One of the reasons, major reason, is because ADHD and other behavioral problems are common, okay? They're not always caused by Huntington's. What's the risk of getting a genetic test? So take that scenario. My child is at risk for Huntington's. They're diagnosed with ADHD. Why can't I get the genetic test right now? So that symptom, the ADHD, may not be related to Huntington's. So here's an example. Let's just say that the child has a CAG repeat of 43. And everything is an estimate, but in general, that child is not going to manifest Huntington's disease until they're 45 years old. And that means that the attention deficit is probably not related to current or to juvenile onset. And so if we got the test for that child, that means that child is now what we call pre-symptomatic testing. So they have to live with the burden. And if the child would be aware of it, that's the whole thing. You can't test a child without their knowledge of what's happening. But now that child carries that information of knowing that they're going to develop it as an adult. So these are all important things that I hope we talk about more. It's important to talk about, and I think it's all important as a community to talk about how we manage these challenges. And once again, like I said, experiences for one family can be way different than for another. So one thing I wanted to mention is the course of disease in AOHD versus JOHD. As I'd mentioned before, hyperkinesis, a lot of movement, hypokinesis. And the course of disease is the same for everybody with Huntington's, no matter when you get it. It's just that the course of disease is shorter the earlier you get it. So just look at this top arm up here. The yellow bar is what we call pre-symptomatic, where you carry the gene, but you have no symptoms. And then the green is usually the earliest, hyperkinesis. And for AOHD, the time of diagnosis is usually right when hyperkinesis starts. But for AOHD, hypokinesis, the bradykinesia, those kind of things, that happens. It happens for most patients, and it's usually towards the end of the disease. And then you can see here, as we go down with earlier onset, the whole disease course gets really short, right? So that means the yellow bars, the pre-symptomatic, become shrunk, the green bars, the hyperkinesis. And for the most part, what it means that for something like childhood onset JOHD, we're making the diagnosis, we miss the whole hyperkinesis. That phase of the disease has already come in. And so oftentimes the time of diagnosis is made when they're already in the phase of hypokinesis. They're already farther along in the disease than somebody with adult onset. So how can we understand this better? How can we know what's going on with the brain in JOHD? How can we make the diagnosis better? So this leads me to the kids JOHD study. So this is a study at the University of Iowa. Yay, there we are. And by the way, we got a whole bunch of snow yesterday, a snowstorm here. I bet it's nice there. This is a study of brain structure, which is looking at volumes in the brain, using MRI, brain function, by thinking skills, motor tests. All families travel to Iowa City for participation. Subjects are children who are ages 6 to 25 who've been diagnosed with Huntington's. We try to do it annually. Since 2012, we've had 38 participants, and those participants have come multiple times, sometimes many, sometimes I think 5, 6 times is our top. So we're phenomenally grateful for the opportunity to do this. And most are seen shortly after diagnosis. And so it's not that they have been sick for a long time and then they come. Many are seen early in the course of their disease. So this is just a picture of what we call the glass brain, just so that you can see inside it, because the area of the brain that's affected most in Huntington's disease is called the striatum. And that's two pieces of the brain called caudate and putamen, but it's really right in the middle of the brain. It's highlighted in red here. And this is the volume of this area predicts when you have motor onset. So we can tell when it gets too small, that's when you start to get motor onset. And once it hits a certain volume, okay, now we're going to have problems. And the smaller the striatum, the worse the symptoms. So that's an area of the brain that we want to focus on in all studies of Huntington's. And this is actually a graph of kids who don't yet have Huntington's disease, meaning that they don't have JoHD. This is from our Kids HD study. But we see that kids who carry the gene, who are going to get it later on in life, they're in the red here in this graph. That's the red area. And I want to call your attention to the fact on the y-axis, the vertical axis is how big the striatum is. And I just want you to focus here on the age 6. So remember, these are kids who have the gene. They don't have JoHD. They're going to get Huntington's when they're 40, but their striatum is too big early on. When they're 6, their striatum is too big. So it grew too big. But once it grows too big, it changes. So you can see here, and it's normal to change over time. And the green line is normal development. And for those of you who have children who are adolescents, you know that this is the case, that the time adolescence is the time of major brain change. So the green line is normal. During adolescence, it peaks and then it gets smaller. But how the brain changes when you have this gene is way different, right? Once again, it starts out too big. So what we think is happening in JoHD, we see that with each repeat, that being too big early on and how steep the slope is of your change depends on your CAG repeat. So slope just means how steep this change is. This is not a very steep change at all. This is a very steep change. The higher the repeat, the bigger the striatum is when you're very young, and the steeper the fall. So that's what we think is going on with JoHD, is that the striatum starts out really big very early in life. And the bigger it is, the faster it gets smaller. And once again, once you reach that threshold of too small is when you get motor symptoms. So these are the dotted lines that we think are happening in the highest CAG repeats, right? So very early in life, very large striatum, but then it gets really small early on. So this is just one example of one of the things that we're hoping that we may help with the diagnostic challenge, because remember the whole concept of having that diagnosis based on your motor symptoms. If we could find out from looking at brain imaging whether or not someone's brain is changing, right? If the striatum has a slope like this, and if you could see, even if your child doesn't have the motor symptoms, if you could see that the striatum is changing over time, which is not normal, could we make the diagnosis earlier? So this is an example of one of our subjects in the protocol. And all of the blue dots are normal, healthy children, and it's matched. So this is a time window. It's only 6 to 12. And this is all the same gender. And in the blue is what you would expect normally. So this is normal development. You can see there's a little bit of downtrend because we're going to be hitting adolescence here soon. But for this subject, when this subject first came in at age 7, the volume of the striatum was normal, absolutely right there, slapped up normal. You could see, though, probably earlier in life, it was probably much bigger. But then by the age of 9, when there was no motor symptoms, you could see that the striatum is now below normal. And most importantly, if you connect the dot between here and here, that slope is like this. It should be like this. And then by this time, we see that the onset of motor symptoms has occurred. And so that's when the diagnosis was. And so you can see here this change. So this makes us think, is it possible that if we were to get on children who are at risk for Huntington's, serial MRI scans. And if we saw a slope like this, if we saw a change in striatum volume, could we at that point pull the trigger on a genetic test, even though they didn't have any motor symptoms? It's something that's important to think about, something that we need to work with in the community, with the neurologists who are taking care of these kids. And it's one of the things, like I said, that's been such a privilege to be able to understand better from the families that have participated in our study. My lab hasn't had a group picture in many years. Actually, I think we finally put together a Zoom picture recently, but just because this was, of course, taken before the pandemic, we could be together in small groups or close together. But I want to thank everybody in my lab, because this is really something, this is a project that we've been doing for many years now. And of course, what's really important in our motto is, of course, absolutely, we're so grateful for everyone who comes to Iowa and participates. It's not a small journey to Iowa. And sometimes travel can be kind of scary, but we continue on. And once again, we thank everyone who has participated and everyone in my lab who's worked so hard. So I'm going to open it up to questions there and be happy to answer anything.
Hello, Peg. It's Stacy, Corey's mom. How are you?
I'm great. How are you?
Good.
Good.
Has there been any studies on medications that would help the pain and the itching for JHD?
Great question. Not any studies, but I can tell you that in general, I think that there has been just clinical anecdotes. So physicians who have tried this and have tried that. Sometimes, so for the itching, sometimes topical remedies. So I've had families tell me that just a cold compress, just to help decrease that. Sometimes Benadryl, like a Benadryl cream, can do that. Others have tried other medications. So for instance, you may have heard the medication Neurontin, which is, it helps for nerve pain, because we assume that this itching is a neurologic, right? It's probably something in the brain that's telling the skin that, you know, even if there's not a rash, it comes from the brain. So sometimes medication like Neurontin, which helps nerve pain, can help. But once again, I've had families tell me that they have some relief with topical remedies, cool compress, Benadryl cream. And then, and sometimes even you can take Benadryl orally, right? You can do that as well. One thing about Benadryl orally is that it makes you really sleepy. But sometimes that's good if you're really having a major itching thing. With the pain, oh my goodness, it's anything. Obviously, the one thing, all of these symptoms are difficult, but of course, pain is something that you never want to see your child in. All the pain remedies have been tried. I don't think that there's anything necessarily better than the others, but everything from non-steroidals to also too sometimes, because if the pain in the legs is due to stiffness, then sometimes the medicines that are used for what we call, well, stiffness, and so medications like baclofen, so that's for spasticity, people who have spasticity in their legs. Baclofen is a medicine. It's a muscle relaxant. Other things that can help the muscles relax are medications like Valium-like medicines like Klonopin, and sometimes relaxation of the leg muscles can help with that pain. Otherwise, pain, non-steroidals like ibuprofen, but even up to the opioids. And in general, opioids are just a good pain relief. And of course, you have to be careful with those. But any of those, and I think it's important because like that's completely different classes, right? Pain medication, but also make sure you try, especially if it's leg pain, to see if you can make sure that those muscles are relaxed as possible.
Hi, I just have a question about medication given for other symptoms in a small child that could accelerate the symptoms of juvenile Huntington's. If you had a child that was given ADHD drugs or some other kind of drugs because they've been misdiagnosed, or perhaps have a dual diagnosis, has there been any studies about drugs that would be almost a switch to turn on the JHD symptoms?
That's a great question. It's a great question. And let me just talk about that. You're pretty knowledgeable about it. Sounds like you've already had some experience with it. But for the most part, when we think about the chemicals in the brain that govern movement, it's one chemical. This is oversimplification, but it helps. So it's dopamine. If you have too much dopamine, you move. If you don't have enough dopamine, you're slow. And stimulants increased dopamine. And so there's this, I will call it a theoretical risk, meaning that it seems if you give a stimulant that it would worsen Huntington's disease because you're giving it too much dopamine, and that's a problem. It's only a theoretical risk. We don't yet have any evidence to suggest that a stimulant would worsen or bring on the disease more quickly. It's something that now we're able to, I think, because JoHD is so rare and the large databases that would allow us to look at this. So our database is still relatively small to look at this, but we're now in this study called Enroll, which now has 23,000 data points. Very few of them are juvenile, but there's a growing number where we can look at this directly. There is a possibility that the stimulants help in terms of that they're not even harmful, that they potentially are protective. Once again, we don't know that. And so I think what's most important is that, and I tell most of my patients this, if that stimulant medicine is helpful, if it really helps the child functionally, then continue to use it. Because at this point, there isn't any evidence to suggest that it's dramatically better or worse. And so, like I said, it's something hopefully that we'll have a little bit more data when we have the big Enroll set, and then we can look at that. If we can have at least 30 or 40 children who have stimulant medication, and then we can follow them longitudinally, we can try to see whether or not it's helpful or not. But I can tell you clinically, there doesn't seem to be a lot of evidence that it dramatically makes things worse. And in many patients, it's just helpful for them. They do better. They are able to concentrate, or it's able to slow them down. Something that we continue to really focus on.
Hi, Peggy. This is Cassandra, Daniel's mom. So my question, you talked about the masked face. You said that you would hit back on it about it being towards the end. So my son wakes up Sundays and like half of his face is, if he had face paralysis, like he can only talk out of one side of his face. And the neuro said that it could be like seizure related, but he hasn't even been diagnosed that he's had seizures. So I don't know if this is like common in kids with JoHD or what you can tell me about masked face.
Yeah, so masked face should be something that's symmetrical, right? So when you have just low movement, it's symmetrical. When you have a change in your facial structure that's one side or the other, what we call lateralized, whether one side or the other, that suggests something else going. So the thing that suggests that it's a specific region of the brain, one area. And so it would suggest something like stroke, which is not likely to happen at all. But a seizure would affect one side and not the other. So that's probably why the neurologist suggested that maybe it was a seizure. And you can, once again, with seizures in JoHD, they can be lots of different kinds. So remember I said the grand mal seizure, or just the absence seizures, but you can have localized seizures where you have just one side of your body or potentially one side of your face. And so it doesn't, if it's lateralized, if it's one side or the other, then it seems a little bit less likely to be just masked faces. So I think that the neurologist that you mentioned suggested, has your child had an EEG yet to look for seizures?
Yeah, he did, but I don't think it was like, he didn't go to sleep. They have to be sleep deprived, and he didn't actually go to sleep for the EKG. So I think he has another one to be ordered to be done. So hopefully.
You mentioned that this was also like when he wakes up in the morning, right?
Yeah, he has insomnia, so he like has trouble sleeping at all.
Yeah. And then does this get better? Right? Is the where it looks like his face is drooping? Is that get better over time? If he wakes up and moves around a little bit, is it better, or is it always droopy on one side?
No, it's always droopy. I feel like some days it's worse than other days. It's like very noticeable some days. And I don't know if like maybe he had a seizure and I didn't notice it. And then because I usually notice it in the morning, and then he'll have it like all day. Sometimes it's even 2 days, and then the next day he gets better. Okay, I see he's able to move his whole mouth again, but it does last.
Okay, so let me talk about another possibility, because it's unlikely that you would have a seizure that long. So if you were having that amount of seizures where you're seeing this change for days at a time, you would have picked it up on the EEG, whether he would have fallen asleep or not. So it could be dystonia. So it could be that one side of his face is more tight than the other. So that whole notion of muscle tightening. So that's one possibility, that there's just a difference in essentially the motor control of his face. Because that seems more likely than seizures, now that you described that more. And here's the thing, moms know so much more than everybody else. So once you describe it a little bit better, that does not sound like a seizure, because that would be, if it's really there all the time and just a little bit worse in general when he's tired or just waking up. So it may just be a difference in his face in terms of motor function. Does that make more sense?
Yeah, that makes sense. Because he does, now that I'm thinking more about it, he sleeps in like fetal position, and there's a lot of stiffness going on around his whole body currently. So
Yeah. So,
I just
and in
didn't
general,
really-
that's less scary than seizures that last for days. That's just not happening. I don't think that's what it is. Like I said, if he were having seizures that were last for days, he doesn't have to go to sleep for the EEG to show that. And especially if it's just this and he's not having any other symptoms of seizures, then I don't think you should worry about that at the moment. I think that's probably just related to motor coordination. Some of the things that are the places of the body where you have the most small muscles and the coordination that's needed is this speaking and swallowing. So face and all of those tiny muscles that need to coordinate how we speak and how we animate our face. Those are the muscles and that coordination that can be really affected by the motor symptoms.
Yeah, thank you.
Good morning. I have one other question. It's about diet. I'm just curious to know if both during the symptomatic stage as well as before onset, if there's been any research into diet as it relates to either symptoms or onset. Is for instance, a plant-based diet better? Gluten-free, no sugar, no processed foods, those kinds of things. Is there any linkage?
So there hasn't been any studies. Like I said, unfortunately, because JoHD is so rare that it's hard to get enough studies done on just the children. I can tell you in general that healthier is better. I know that sounds a little silly, but there's been nothing to suggest that there's a specific diet. So there's nothing to suggest that gluten-free is better, nothing to suggest that sugar-free is better. But in the grand context of things, processed food and sugar in general are not a part of a healthy diet. And I think the general adage of minimizing processed food, minimizing sugar, and having a healthy diet throughout is important. Having said that, there's still also just a lot of variability, and families and parents will know what their child reacts to best. There's some foods that just aren't tolerated just because of that. That's the child, and that child has that kind of GI system. So I don't think there's anything specific to JoHD, with the exception of healthy is best. And there's still development going on. There's still brain development going on. There's still body development going on. And I think a healthy diet is important.
Thank you. Do we have any other questions for Dr. Nopoulos? No? Okay, we thank you so much for being here today. And I cannot wait to hug you and your team in person.
I know.
It'll be great when that day happens, but we totally respect that decision, and we will see you when we can.
We're going to have such a party.
We sure are. I can't wait. Thank you.
Take care.